So good morning, everyone. It's great to see you all here. And after the first presentation, I know that there are a lot of physicians in the room. I just want to have a show of hands. How many nurses do we have? Yay! Okay. And social workers? Yay! Not very many social workers. Okay. Thank you. That just helps me to kind of get a clue of how to direct this. So I want to thank Alex and the rest of the Pathway team for inviting me here. I met with them this last fall when I was based in Edinburgh and doing some work on homelessness and also the history of English poor laws and how they are affecting the United States and even Seattle today in terms of health and homelessness. And as you already know, I am a nurse. I'm a nurse practitioner, family nurse practitioner. I went directly into that because I knew that there was no way I wanted to be a hospital nurse, not to put any diss on hospitals, but my heart has always been in community and primary care. So for the past almost 35 years, I've worked actively as a nurse practitioner in a variety of different settings on both coasts of the United States, in Virginia, which is my home state, Washington, D.C., Baltimore, and more lately, for the past 24 years in Seattle. My doctorate is in global health, and so I've also worked internationally in Thailand, working with street-involved children and also sex trafficking, and in Venezuela, and also in New Zealand. So just a little bit of background on that. And what I want to talk with you today about, and obviously it's around experts by experience. I love that term, by the way. I've started to introduce it as I'm back in the United States. It's not something that we use. And I just have to tell you, I was facilitating a panel discussion last week at an event on health and homelessness in Seattle. And I used that, and someone who was an expert by experience but didn't know that term was like, yes, that is it. We use consumer. That's an American term for it, which really makes no sense to me. So I want to talk with you a little bit about my own journey into and back out of homelessness, how that has affected me as a person, and more specifically as a nurse, as a healthcare provider, as a teacher. I'm a professor. I teach population health and health policy and politics at the University of Washington in Seattle, and also how it's affected my policy work. I'm currently on the policy committee for the National Healthcare for the Homeless Council. So first of all, this is a weaving of community ideas about, I do an exercise with lots of different, like whether it's students or community members, policymakers around the meaning of home. And I feel pretty strongly that, and this, I know that there are different feelings about this, but poverty tourism or poverty safaris, I personally have an ethical ick about. I think that it's not something that is very ethical, but of doing a kind of a simulated exercise for everybody about what the meaning of home is for us can be something that gets across lots of different experiences. And this is a weaving of some of the examples of people in terms of the meaning of home for them. So first of all, just to kind of show you here, and I guess over here as well, Seattle, Washington, which is where I live and work currently, is in Washington State, so it's just a little bit south of Vancouver, British Columbia, for you. And then my home state of Virginia, which is, of course, right below Washington, D.C. This is the current. It didn't have the source that got up on this slide, but it's from the 2018 point in time count that we do nationally in the United States, and in terms of homelessness. And this is for literal homelessness. So it's people that are living in emergency shelters or who are counted out on the street. And as you can see in the dark areas, the west coast of the United States, for a multiplicity of reasons, currently has the highest proportion of homeless people in the United States. And you can see there for Washington, the 2019 count is not quite available yet. But we had over 22,000 people who were homeless. And of that, over 12,000 people were homeless in King County, Seattle, Washington area. So we have a very significant and very visible homeless population. And I have participated as the lead for the University of Washington. It's a district around the university district around the University of Washington area for the past 3 or 4 years for the actual literal street count. And I can tell you that this past January, we always have the point-in-time count at the end of January each year, that the previous year, 2018, we counted 14 people who were literally sleeping rough on the streets. And this past January, it was 148. So we know that it is increasing significantly in our area and how to deal with that. Okay. So I want to start off by reading to you the very first part of the author's note to my first book. I'm working on my third book now. It's called Catching Homelessness, A Nurse's Story of Falling Through the Safety Net. A few years ago, while working with Public Health, Seattle and King County on a medical respite project for homeless youth, my own homeless shadow resurfaced. I was in downtown Seattle at the YWCA Women's Shelter, waiting inside the front lobby for the rest of our group to arrive. We were scheduled to have a tour of the facility to see how they ran their medical respite program. I'd taken the city bus and had purposefully dressed down in jeans, a sweater, and a raincoat. It was late afternoon, raining outside, and I saw soliciting, pimping, prostituting, and drug dealing happening on the sidewalk in front of the shelter. The members of my medical respite group were buzzed in the front door. At the same time, a homeless woman resident walked up to me and asked, "Did you stay at a hotel last night on Aurora instead of here again?" Aurora Avenue is one of Seattle's main prostitution areas. I looked up at her in alarm. "I'm sorry, you must have me mixed up with someone else. I'm not staying here. I'm just visiting." The people in my group overheard this interchange. Later, they teased me about it, saying how preposterous it was. I was a university professor, for God's sake. There was no way I could be homeless, much less a homeless prostitute. But I couldn't shake the feeling that my cover had been blown, that I'd been found out, that my homeless shadow was showing. "You were homeless. Why? What was wrong with you?" Those are the questions people ask me, or want to ask me, whenever they discover I was homeless. Coming out of the closet about my own homelessness was never an option for me. It could derail my career, hurt my family, and marginalize me even more. It was largely why I had moved across the country to Seattle, to escape the memories of having been homeless in my hometown of Richmond, Virginia. But standing there in the YWCA shelter, I recognized the irony and the hypocrisy embedded in my reaction to the woman's question. Here I was, an outspoken advocate for people who were homeless, while secretly judging them, and by extension, judging myself. Homelessness is exhausting and soul-sucking. Homelessness has marked me. Like the star-shaped surgery scars on my belly, the body harbors secrets. Homelessness is a type of deep illness, a term coined by sociologist Arthur Frank for an illness that leaves you feeling dislocated, an illness that casts a shadow over your life. That shadow never completely goes away. At some point, it was time to acknowledge my homeless shadow, time to remember. And this is a photo of the area of the YWCA in Seattle. So this is a photograph of me in my younger days. Don't know, I look cute with bangs, never again bangs. I was 6 months pregnant with my son at the time, and I'm washing the feet of a homeless Vietnam vet in my hometown of Richmond, Virginia. At that point, I was working for the Crossover Clinic, which is it's still in existence, a very conservative Christian evangelical clinic. And I was working in this building, which is very ugly. It's called the Richmond Street Center. It no longer exists. It's now a college dorm. And it was a multi-service center that had social workers, chemical dependency workers, the health clinic, and some emergency housing in the area. I show you a photograph of this because I also want to make the point, and I think some of the earlier comments from today are that where you work and even the architecture of where you work can be re-traumatizing in some ways. And so, even like how uninviting this building was is part of my story. This, by contrast, is where I work now. You can see over here in the background, I call it the Tower of Sauron, but it's the main tower for the University of Washington. And in the foreground, obviously a homeless tent encampment. And so this is our reality, that we can't ignore homelessness right in our backyard and how to work on that. The experience of homelessness has affected my direct care. I feel, at least for me personally, of maintaining some type of individual care direct practice is extremely important to inform my teaching, but also my policy work as well. So it has definitely kind of changed my perspective. I'm not as likely to go to all of the traditional, like for instance, cardiovascular risk factors. I'm more likely, like with this young woman who did give photo consent, by the way, for this, to talk about what's on their mind right then, what they're most wanting, and also to, once you start to establish a relationship, to get into adverse childhood events. We know from research that a fairly large proportion of even like our adult patients who don't have any other of the traditional risk factors for cardiovascular disease, if you get into it, they have had really significant traumatic childhoods, and we're not doing a very good job internationally of how to address that. So I know some ways I'm preaching to the choir. A lot of you know about the interaction of trauma and homelessness, that traumas, especially again adverse childhood events, often precede, lead to homelessness, and then they get re-triggered, and homelessness itself is a risk factor for more trauma. And the other ones that I want to point out that might not be as familiar to you, that are extremely important to me in my work, the role of historical trauma. So for instance, Seattle, Washington, it's named after Chief Seattle. It's the major city in the United States that's named after a Native American. And a significant number of our homeless people are of Native American heritage. And the other one is sanctuary trauma, and that is that when we're trying to do good, we're trying to provide sanctuary, outreach, healthcare, that we can then end up re-victimizing people who we are trying to help, including like how ugly the Richmond Street Center was that I showed you. And this is from downtown Seattle, a public art institution, just pointing out again that now Chief Seattle, the streets are our home. Native Americans are about 6 times as likely as other people in Seattle to be homeless. The other is to understand, like for all of us, no matter what our work is in this field, to understand trauma and its impact, to ensure cultural humility. And the other important one, which goes to experts by experience, the consumers, is to support control, choice, and autonomy, and also to really not in a token way, because it's really easy for us to kind of get a token, oh, we have a homeless person on this, on this committee, so everything's okay. But to, in a meaningful way, to include people who have the lived experience of homelessness in service provision, in planning services, in research. We have consumer-directed research that we're starting to do more often in Seattle. The other one is to also support hope and remember that recovery is possible. You're not like damaged goods. And the other thing I wanted to just get into towards the end of it is something that I'm currently working on. I'm the director of the Doorway Project. It's a state-funded project in the University District of Seattle to try and come up with a different upstream prevention approach to ending youth homelessness in the University District, including among our own students. We have a population of about 60,000, and Seattle is similar to London in terms of being extremely unaffordable for many people. And so we're really trying to kind of across the board do prevention in terms of homelessness and connect people with what they need. So we're starting to do a series of pop-up community cafes until we get the actual bricks and mortar community cafe. And this is based on a model in Auckland, New Zealand called the Merge Cafe, and also one that I did a little bit of work at in Edinburgh this past fall, the Open Door Cafe. So it's I know you have the Dragon Cafe here for mental health, but this is going to be much more of an open for anybody in the community to come in, and then we're going to have stealth social workers and nurses to provide the care and the connections that people need to services. And this is based on some community activities of having people even say what it is that they want for this. We're really trying to make this not a navigation or engagement center, but a community cafe, because the young people tell us that they don't want to be labeled, that if they go to a homeless service, they already know that they're having to come in right at the front door and say, I'm homeless, or however that is decided upon. And instead, they want to come in as what they can provide, whether it's music, artwork, what they can give back to the community. And so this is just some kind of drawing about what they want in the cafe, and also going to have some empathy building activities across the board for people who come in. And one of these at the bottom is having open discussions between the public and people with a lived experience of homelessness. And this is one of the iterations of what the cafe space will actually look like. And just one to end on in terms of team building, all of us knowing how to work together. This is an example of an interprofessional teeth and toes clinics, or what we call them, with our health science students. So the woman in the front obviously is the toes part. We have a medical student, a nursing student, and then in the middle in the scrubs is a dental student. And so we're really doing these training programs out in the community. This is in an actual shelter in Seattle, and we help them to learn to work together as teams, but then, just as we heard this morning, to talk about it's not just individual patient care, but it's population care, and to kind of have those stepping back and thinking about it. So these are some additional resources for you on Medical Margins blog, and then the last one, these are obviously US kind of based, but they would cross over. Some great resources for any of you in terms of burnout prevention or secondary trauma. Thank you.